Good morning, everybody. Today, Dr. Stefanie Sins will hold the resident lecture. She's our fourth-year resident and will talk about gallbladder cancer. Please, Stefanie.
So, thank you for the introduction and welcome to today's lecture about gallbladder cancer. On my first slide, you can see an overview about the topics I'm going to talk. At first, the incidence and epidemiology, followed by symptoms, diagnostics, and pathology. And finally, I'll talk about the staging, therapy, and prognosis. So as an excursion to history, gallbladder cancer was first described in 1777 by Maximilian de Stol. He was a pathologist in Vienna. Gallbladder cancer is the fifth most common neoplasm of the gastrointestinal tract and the most common malignancy of the biliary tract. Its worldwide incidence is, with 2 per 100,000 people, quite low, which might be due to the rising rates of cholecystectomy. It affects 3 times more women than men, with a median age of 67 years. The incidence of gallbladder cancer has a high geographic and ethnic variability. As you can see on this world map, there is a very high incidence in South American Indians with up to 27 per 100,000, and also a high incidence in Northern American, in North India and Eastern Europe. This variation suggests the role of genetic and environmental factors for this development of gallbladder cancer. This brings me to my first question to the audience, which could be possible risk factors for development of gallbladder cancer?
Gallstones, polyps, for example.
Chronic inflammation through infection or cholecystitis.
Porcelain gallbladder.
Yeah, thank you. So you can see the risk factors. Considering all risk factors, gallstones have the highest risk for developing gallbladder cancer with up to 90%. This might be due to the gallstones creating a local mucosal irritation, which leads to chronic inflammation, and this causes DNA damage, which activates the DNA repair mechanisms with releasing cytokines and growth factors, and thus predisposing cells to oncogenetic transformation. Also, this gallstone size matters. With increasing stone size about or greater than 3 centimeters, the risk for developing gallbladder cancer tenfold. So it's 10 times higher than compared with smaller stones. And also the stone type matters. So in the American Indians, as we saw on the slide before, the main type of gallbladder stones were the cholesterol stones. The chronic inflammation also results in calcium being deposited in the gallbladder wall, and therefore the gallbladder acquires a bluish color and becomes fragile, hence the term porcelain gallbladder as we know. Also, congenital malformations such as long common channel defeats the gatekeeper function of the sphincter of Oddi, potentially allowing the pancreatic secretion to regurgitate into the bile duct and into the gallbladder, and therefore leading to malignant changes in the mucosa. So to take a look back at our world map, in the Andean area, congenital malformations and chemical exposure are the main causes for cancer, as well as gallstones and polyps in the other high incidence areas. So, next question to the audience: which could be typical symptoms for patients with suspected gallbladder cancer?
Abdominal pain in the upper right quadrant.
B symptoms and jaundice.
Thank you. So, the symptoms are quite unspecific. Most of the patients have upper right quadrant pain, which is due to an invasion into the cystic duct, leading to obstruction and causing acute cholecystitis. dyspepsia, malaise, and weight loss is due to spread into adjacent liver, as well as jaundice, which is due to invasion into the common bile duct. But in most of the cases, gallbladder cancer is an incidental finding after cholecystectomy. So the diagnostics we can do quickly. We at first have to do the medical history, physical examination, as well as the computer tomography. In cholestasis, we also can do an MRCP. We have to do blood analysis with tumor marker CA19-9. And here on the left side, you can see a wall thickening in the lower tumor states, and in advanced gallbladder cancer on the right side, you see liver infiltration already. Pathologically, there are 85% adenocarcinoma, 10% anaplastic carcinoma, and 5% squamous cell carcinoma. 60% are located in the fundus, and 30% in the body, and 10% of them in the neck. So back to our overview, we already talked about the incidence, epidemiology, symptoms, diagnostics, and pathology, and now we come to the staging. The TNM classification, so T stage 1 is already subdivided into 1A and 1B. You can see on this picture the T1A means an infiltration into the lamina propria, T1B into the muscularis. In T2, we already have perimuscular connective tissue invasion without spreading beyond the serosa. This is defined as T3, which might be facilitated by the lack of serosa adjacent to the liver, which allows infiltration to the liver. T4 tumor signifies spread to 2 or more adjacent organs, or also the vessels like the portal vein or the commune hepatic artery. And for all of you who are interested in the pathology, you can see on this picture the different layers. Here the lamina propria, the muscularis, and the perimuscular connective tissue. To go on with the staging, the lymph nodes are classified as N0, as we all know, with no lymph nodes, and N1 regional lymph nodes, which include the cystic duct, common bile duct, periportal, and common hepatic artery lymph nodes, as you can also see on this picture here. In this table, you can also see an increasing tumor infiltration leads to an increase in the lymph node metastasis. So the frequency of lymph node metastasis correlates with the depth extension. To complete the TNM classification, 0 is no distant metastasis, and 1 you have distant metastasis, where lymph node metastases also are included, like the para-aortic, the celiac trunk, the periduodenal, the peripancreatic, and the superior mesenteric artery lymph nodes, as you can again see on this picture. Also, if you have hepatic metastases, which are the most common metastases in this disease, and in 25% we have peritoneal carcinomatosis at the time of diagnosis. As an overview, you can see here the UICC stages. So stage 1 is the T1 with no local or distant metastasis. Stage 2 is T2 with also no metastasis. Stage 3 is subdivided into 3A and 3B. 3A is T3 without metastasis, or 3B with T1 to 3 grade with positive lymph nodes. And stage 4 is mostly a T4 invasion and or distant metastasis. So to the therapy, the only curative therapy for gallbladder cancer is the surgery with R0 resection. But this is limited to the former seen UICC stages. So let's take a look at the different therapy options in stage 1. And for those who can't remember the stages so quickly, I put it here in the upper right corner. In stage 1, you do a simple cholecystectomy, but due to literature, this is only for T1A cancer, so where the lamina propria is invaded. T1B is already recommended to do therapy like in stage 2, which we are talking about now. Stage 2 is extended cholecystectomy, which means, who knows?
Wedge resection of the gallbladder bed.
Yeah. And also lymph node dissection. Why is that so? Because in the studies you can see compared T2 extended resection with simple laparoscopic cholecystectomy, the 5-year survival rate rises up to 60 to 80% in stage 2 with extended resection compared to laparoscopic resection. And also you can see in T1B the survival isn't that good either, so it's recommended that you also do the extended resection here. Stage 3 and 4 are treated similar. If you have a curative intent, you have to do a radical resection, which might also include extended right hepatic resection, pancreatic duodenectomy, and resection of the portal vein. And if it's not possible, you just can do a biliodigestive bypass or stents. The adjuvant therapy, as an adjuvant therapy, there aren't many retrospective trials, so most of them assess a regimen combining gemcitabine chemotherapy with followed chemoradiation. However, gallbladder has a low incidence in the Western country, and therefore no randomized controlled studies are available at the moment. As the gallbladder cancer has a high rate of local and distant metastasis, the prognosis of this disease, if not diagnosed at a very early stage like 1A or T1A, the prognosis is inferior to all other types of biliary tract cancers. The 5-year survival rate estimated in type 1A was, as we saw a few slides before, about 100%, but there are some reports showing that bile duct or bile juice leakage during the laparoscopic cholecystectomy is associated with a high risk for developing peritoneal metastasis or carcinomatosis, and also tumor recurrence at the trocar sites. The 5-year overall survival rate is only about 5% in gallbladder cancer. So at the end, or nearly the end, some algorithm, if you have gallbladder cancer, mostly diagnosed by histopathology, you have to know the T stage for further treatment. If it's a T1A, you have to know if the cystic duct margin is negative, as you can see here, and if so, you don't have to do any further treatment. If the duct margin is positive, you have to do the re-exploration, also in type 1B, T2, T3, and T4, and if it's resectable, you have to do a radical operation. If it's unresectable, it's the same like in metastasis. In distant metastasis, you can only have palliative treatment and best supportive care. So to sum it up, gallbladder cancer is a disease of the older population over the 6th decade with an extensive geographic variance. It is mostly associated with gallstones and chronic infection or cholecystitis. The T&M classification is predictive for its outcome, but it stays a disease with an overall poor prognosis and a 5-year survival of 5%. Thanks for your attention.
Thank you very much for this excellent review. I think you present what's very important. I think the best chance of survival for someone with gallbladder cancer is to go to the right place. I mean, this is clearly a difficult disease, even if at the end of the day you just do a cholecystectomy. I think this is very important. And even in center of expertise, they don't see so many, as you have shown in Europe, is not the case. Maybe one point you associate, which is clear, gallstones disease with gallbladder cancer, then the question comes, should we take out the gallbladder to everyone who has a stone and therefore eradicate this disease? And the answer is pretty clear. In area that you have shown, like in South America, when there was genetic predisposition for this disease, the answer is yes. So here there is prophylactic, clearly a benefit of treating asymptomatic gallstone disease, which is not the case in area. We will kill probably with more problems by doing that versus the risk of gallbladder cancer. So there is no reason to take out asymptomatic gallstones because of this disease. You have shown also very well the staging. I think it's very important. There's still ongoing work. There is group around the world that try to redefine this, so discuss treatment. There is novel treatment, novel chemotherapy. The staging is very important here, and often you need a lymphadenectomy, which is not an easy procedure. It needs to be done right. You need to skeletonize the porta, etc. So that's been done again with people with experience, and this patient, of course, need to be discussed in multidisciplinary MDT for the best of the treatment. But irrespective of everything we have today, you have also shown that most of these patients do not survive very long. So the natural history of the staging make the difference for these patients. I just wanted to make this comment. You already say most of this in doing talk, but I think it's important to remember that. And there is a differential diagnosis. Many of these diseases are not clear whether they are gallbladder cancer or intrahepatic cholangiocarcinoma. This is often in the differential diagnosis, and that's also a difference. If you have an intrahepatic or gallbladder cancer, the prognosis is completely different, and the treatment is different. So very often we try to differentiate. It's not always possible, in fact, because the histology is very close. I don't know if there are any question here.
Thank you very much for the excellent talk. I do have a question, because as far as I know, 2 years ago the TNM classification changed a little bit. The T2 stage was subdivided into 2A and 2B, and 2A is the infiltration to the peritoneal surface and 2B to the gallbladder bed. So I just ask if there is some implication on the prognosis and the therapeutical consequences, because if you do have a perimuscular infiltration to the peritoneal surface, it's a question if you do have to resect the gallbladder bed of the liver. Are there data coming up to that?
I mean, it's a good question, number one. And every time they go from, there is no randomized study or whatever that test one treatment with the other one. They have huge database, discuss usually experience between Asia and here, and try to differentiate. And there is indeed a difference in prognosis, whether it goes to the serosa or whether it goes to the intrahepatic. As that difference in the treatment, this is questionable because this prognosis is anyway poor, regardless of what to do. But many centers now will go for extensive surgery. We do PET scan, is also important, I think, in this disease, because you have a good, very sensitive to PET. A negative doesn't mean, the negative means often that there is really no tumor. So here, if there is no extra hepatic or local regional lymph node, then you go for extensive hepatectomy. I think is justified in this case if you have invasion. If you just have the serosa, then what we do here, we will do indeed the staging that you have shown. We will see whether or not there is invasion in the liver, and if that's the case, it makes sense that we will proceed with a major hepatectomy, which usually is a trisectionectomy that we do in these cases.
Thank you for the talk. If you, in case of surgery, if you go perform laparoscopic cholecystectomy for another reason, you think it's cholecystitis or symptomatic cholecystolithiasis, and you come up with you see that it's gallbladder cancer in the end, do you stop the surgery and refer to a bigger center, or do you perform cholecystectomy and refer then?
I think in most cases it's hard to tell during the operation if it's cancer or not. Most of the times after the histopathology shows us that it's cancer, and I mean T1 or 2, I think it's quite hard to tell or to see that it's cancer. And yeah, it maybe also depends how far you've already in your operation?
I think it's a good answer, but you mean histologic diagnosis during surgery or just suspicion? Well, so it's very difficult to differentiate anything. I mean, any acute cholecystitis or whatever may look like cancer. So here, if you probably have to do some histology. If you're early in the stage, that's correct. If you've already transected the cystic and or the duct or artery, then in some way, I think the best way is to call. I mean, if you a general surgeon doing a cholecystectomy is to call either in your hospital or to call outside where to go. It's not a very frequent situation. Often you may find later on, you need always to look at the histology of the gallbladder. There's some story that you do it and you forget to look at the histology and there is a cancer and you discover that 6 months later. That's very good for lawyers. It's not good for patients, not good for doctors. So we always have to read, and that's not true just for cholecystectomy, for many things, because that's where you may find incident. But during surgery, usually it's quite pretty advanced. If that's the case, and you do a biopsy, it's positive, then I would stop. If you can, I would certainly stop, because you need a staging here. You cannot just operate. You need to do all your MRI, your PET scan, whatever. Otherwise, you will not help the patient in this situation. And if it's not the case, then I will probably do a minima. I certainly call a team to see what to do.
My question goes a bit in the same direction. If you diagnose a polyp in the gallbladder just by routine exam via sonography, and what would be an indication to perform a cholecystectomy? I mean, I think if there's growth documented over a few months, I would take it out, okay? And I would talk to the patient. I mean, if you have a small polyp of less than 1 centimeter, maybe it's an individual decision to be done with the patient, isn't it?
Maybe I can answer this. So the guidelines are clear. So this is more than 1 centimeter is recommended to do the cholecystectomy, and also progress over time. So growth over time. But in the guidelines, it's clearly marked 1 centimeter is the cutoff. But you can, I think personally, you should discuss that with people. So if you have a polyp of half a centimeter, maybe you discuss that with and can also recommend a cholecystectomy. But the guidelines say 1 centimeter.
I would be astonished if there were clear data saying that a tumor of more than what's the risk in percentage or incidence or prevalence of tumor is. I think it's difficult to say and a difficult situation.
Well, that's the truth for any guidelines in somewhere. Number one, if it's symptomatic, you have to take it out. And usually when you just tell the patient he has a polyp, if he's not, he would become symptomatic because he knows that he has these polyps. So I think you have to be careful. If you go in an MDT, this conference, as a surgeon, and you have a half a centimeter, then you will have a lot of people that will come and say, don't operate. Why do you operate? Need to remember the simple cholecystectomy is not a big operation. It's a nice biopsy. I would not say we need to operate everything. But if the patient is anxious and want to go for that, I will go for cholecystectomy, even if it's a relatively small polyps, versus doing a lot of MRIs, not easy to see whether they grow. It's demanding for the patient, cost money. So, and psychological is difficult. So, I think it's good with the guideline. We can certainly say to the patient, the polyp you have is very unlikely to be malignant. Don't worry. And if the patient prefer that, you can go for that. But if they are worried about this, they may go, because they will go on the internet, they look about gallbladder cancer, they see the data you show here, and the next day they're in your office to have the gallbladder gone often. So I will be indeed a little bit flexible in this. But 1 centimeter is the one you can fight in an MDT. If it's 1.5 or 2, then it's not much to discuss. You need to take it out. Yeah. Okay? Good. Thank you very much. Thank you.